Hello, everyone, and thank you for joining us today. Before we get started with today's content, I just have a few quick housekeeping items. Please note that this presentation is being recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, or financial advice. Please take a moment now to review the screen and review this notice. This webinar is part of the AMA's Private Practice Sustainability Initiative. Private practice is an attractive option for physicians seeking the freedom and independence to practice in a setting that allows them to provide personalized medical care for their patients and is inclusive of practice owners, employed physicians, and independent contractors. Private practice is an important part of the healthcare delivery landscape, and it has been under intense pressure for several years. The COVID-19 pandemic has exacerbated existing concerns of physician practice owners, but has also created opportunities to change and improve healthcare delivery to patients. As part of this initiative, though, there will be additional content upcoming in the remainder of the 2021 year and more to come in the first part of next year. The AMA currently has a private practice sustainability toolkit, which aggregates a number of the AMA's existing resources intended to support private practices. It will be updated with new content throughout the remainder of this year, and you can visit this page to learn what resources are available to you. Finally, I would like to introduce our speakers today. We have Jeanna Gunville, Garrett Jackson, and Lori Oliver from the Polsinelli law firm who will lead us through today's content. And with that, I'd like to turn it over to Jeanna Gunville.
So my name is Jeanna Gunville, and I co-lead our law firm Polsinelli's Value-Based Innovation and Clinical Integration Group, and I'm based in Chicago. My co-speakers are Lori Oliver, who's based in Seattle, and Garrett Jackson, who's based in St. Louis. Our practice spans nationwide, and we do a range of transactional and regulatory work for healthcare provider clients, including physician groups and provider organizations that are seeking to take advantage of different and changing healthcare delivery models and looking for legal and business opportunities associated with innovating and participating in value-based care opportunities as well. Next slide, please. So in our experience working with providers to evaluate their overall value-based care options and opportunities, we come into the process as outside legal counsel at various stages, depending on discussions that have occurred with key stakeholders to date, and depending on where the organization is at in formulation of their value-based care strategy. Our clients' experience with value-based care ranges widely from independent organizations that are really just looking to dip their toe in the water to representing clinically integrated networks that have truly embraced value-based care and are helping to innovate within these models. Our experience overall, though, regardless of when we're engaged and the type of organization that we're working with, we find that there are a series of considerations common to all of our clients that they weigh out when developing their strategy and considering what types of contracting options, whether it's engagement in a clinically integrated network or some other innovative model, is right for them. There are the strategic and operational considerations, such as how will this model be implemented, who will participate, what will be the impact to the overall organization, and does the organization have the correct resources and personnel or the ability to grow those resources to engage in a specific model and build infrastructure and internal knowledge to engage. There are also considerations with regard to whether you and your organization is financially ready to take on risk, or what your priorities are with regard to expectations for participants in the model and what they will obtain financially as a result of participating, as well as whether or not the goals around participating fit with your overall aims financially, and whether or not, for example, you're able to grow participation in the model through reinvestment in infrastructure, that the finances would match up with that reinvestment plan and strategy to engage in the model long term. And further, there are definitely the legal and regulatory considerations as well. And while that's really within my fellow co-speakers' wheelhouse. The path to do the legal and regulatory analysis is really informed by our engagement with our clients on these strategic considerations and these financial considerations as well. So solidifying your organization's overall value-based care strategy and aims and goals, as well as the financial aims and goals, can help to streamline that legal and regulatory analysis as well. So for today, we'll go through these different buckets of considerations for determining what kind of model might be a good fit for you. And then we'll also conclude with a decision tree that your organization might find helpful as you're weighing out what particular opportunity could be a good fit for you going forward. Next slide, please. So you may have seen a chart like this before, where different opportunities and contracting models are presented along a spectrum. This graphic shows some different types of models that are available in the market, and relative level of investment, resources, and also with regard to degree of alignment or relative level of financial risk that an organization takes on when it determines to participate in a specific model. For example, that we have our more traditional physician contracting opportunities on the left-hand side of the chart that require a relatively lower amount of investment of resources and low to no risk to be able to participate, all the way up to our more involved, higher resource, higher intensity in terms of alignment and the possibility to take on risk. For example, in forming a clinically integrated network or participating in a full capitation plan with a payer. So that's that spectrum there to show a few different examples. And when we refer to investment of resources, we're talking about not just investment of individual physician time to participate in the model, but also talking about an organization's capabilities. For example, the available IT infrastructure that they might have with regard to participation, the ability to retain personnel to support care coordination efforts or monitoring and reporting on certain quality metrics as well. Wanted to highlight a couple of the different models on this chart, again, to kind of explain the overall spectrum here. For example, participation in a pay-for-performance type model would require a physician organization to commit in partnership with a specific payer provider partner to meeting of certain quality metrics, and then to commit as well to the reporting on those metrics, as well as potential adjustments as necessary, for failure to meet those benchmarks. This is relatively low in terms of the amount of investment that would be required to participate, and is something that could be participated in through a group that is definitely going to maintain independent and not seek to align itself more closely with other payers and providers as well. On the other hand, kind of moving along the spectrum are examples of participation in an accountable care organization or a clinically integrated network as a participant. And that could involve either sharing an upside or both upside and downside risk. And that might not necessarily involve your organization's formation of a clinically integrated network, but could involve your commitment to participate in one. And so you'd have to adhere to the requirements that are imposed upon both participants in the network and any requirements that are imposed by payers as a participating provider contracted through that network as well. And then finally, in the right column, as I mentioned, you see some of the models that require higher degrees of risk, higher degrees of investment as well, potentially the creation of a new entity in order to participate. And we'll delve more deeply into some of those opportunities later in the course of this presentation as well. These we call some of the more transformational models that involve a significant amount of risk. And they do place a higher burden on organizations with their dedication of resources and time and effort in order to participate and work with these organizations. And as I mentioned, we work with a variety of providers who are evaluating where in this spectrum they might engage, what type of opportunity might be right for them, what might be a good first step also in their value-based care journey as well. And so now we'll talk a little bit more about kind of the evaluation of those considerations as you're on this journey in determining what type of an opportunity could be right for you. Next slide, please. And I'll turn it over to Lori.
Welcome. So I'm going to kick off really our introduction to clinically integrated networks, or CINs or SINs, entirely your preference. But to ground us, CINs are networks of providers working together to achieve the triple aim of improved quality of care, increase access to care, and lowering the cost of care. And they can be a perfect fit for physician groups who want to remain independent and not employed by others, because they allow you to come together with like-minded clinicians and engage in clinical and or financial integration and engage in strategies you could not otherwise engage in without violating antitrust laws. Some CINs also are focused on the quadruple aim, so they're including clinician sustainability and wellness in their goals and objectives as they put the patient at the center of the care. So whether a CIN is right for you has a number of variables, as Jeanna's been outlining, but I always like to start first with strategy and what is your organization's strategy in the marketplace. And that could be as varied as, depending on the size of your provider, the type of your specialty, are you multi-specialty, and are you experienced or learning? So if you're a leading provider and first choice of patients in your community of a certain size, you might want to be the one that's the convener and bringing people together to create a CIN. If your group is more specialty specific, you might want to be joining into another. So as you think through, do you want to be the originator or do you want to be joining? Some of the considerations are the same either way. So for example, on provider selection, how do you think about whether you are ready to be in a clinically integrated network? And how are you going to evaluate other clinicians who join you? So for example, do you know your own numbers? Do you know what your costs are relative to benchmarks in the community around efficiency and other variables? Are you already tracking and have identified key quality metrics and measuring them against benchmarks? Is your practice already using evidence-based protocols to drive consistency and efficiency in care? If you are, you may be well positioned to start this journey, and you may be well positioned to answer those questions when someone else says, where are you, as they're evaluating you as part of their CIN. Another area to think strategically about is kind of the cost versus the benefits. There are definitely costs of both participating and building a CIN in terms of the functionality you need to build, how you're going to fund it. Is it through participation fees or withholds to your reimbursement? And how does all that balance up against your goal of achieving the triple aim and putting the patient at the center of that care? There is definitely functionality needed to succeed in value-based care. So whether you choose the path of a CIN or some of the other models we're going to talk about, you'll need to think strategically about whether you buy, build, or partner, or some combination of those for the services you need to support the enterprise. So some examples of that are when you are in a clinically integrated network working with other providers, the ability to collect data and share that data across the other providers is critical. So that might be a health information exchange. It might be some other method, but it is a functionality that's necessary to really take on care outside your group and understanding the delivery of it. Care gap identification is another example. Are you able to identify those care gaps and then close the care gaps? Population management tools. Are you using registries with certain populations like diabetes or others? And really critical is, do you have an analytical platform that allows you to bring together claims data and real-time clinical data to intervene in patient care and improve outcomes timely, versus you're relying on months old data as you do this? So those are all really key strategic considerations to inform whether you are ready and interested in embarking on this journey. Next slide, please. Then obviously thinking about the financial and risk considerations, and this is kind of two-pronged, both the payment methodologies in terms of how are you going to negotiate with payers to be reimbursed for the activities that you're doing? Will you be looking at models that sit on top of fee-for-service revenue, or will you be trying to redesign into an entirely distinct value-based model? How are you going to, if you're the convener or a participant in a CIN, how are you going to think about the payments to your particular physician group and the rewards embedded in them? And the cost of participation, if you're not the convener, that might be a participation fee. It might also be connection fees if you are connecting to an HIE or some other tools. It may be that the CIN has developed a MSO type model to be able to fund certain investments. So really thinking about all the layers of the cost of participation are important. And then once you're in the mix, how do you manage the risk? So thinking about your population, do you have good clarity on the population that's at risk? Particularly if in an environment of limited resources, you might be applying different tools for the at-risk population versus other patients that you might be seeing. Is your model for your patients or your population a prospective attribution, a retrospective? Are people choosing you based on the insurance product? Is it some combination of those? Those all will influence your strategies in engaging your patients and influence, in terms of influencing the cost, quality, and utilization. Is the benefit design of the insurance product going to support keeping the patient in network with your like-minded colleagues that you've come together with to manage their care? And then lastly, just managing the risk. There are strategies in the payer negotiation of how you might negotiate for risk adjustment or outliers that are tossed out of the financial calculations. But definitely you need actuarial assistance to assist you in making these judgment calls of what different choices mean. And you still may decide that you want to use a third-party insurer to help insure the risk. So lots of interesting push-pulls in this financial and risk area to think about. Next slide, please. And as Jeanna said, our expectation and certainly recommendation is you'd be working with experienced counsel as you work through the legal and regulatory considerations. With that said, we wanted to give you a preview of the types of questions that you'll want to be prepared to answer and work with your legal counsel on. So one is if you're going to create a clinically integrated network, what legal structure do you want? Is it an LLC or something else? And often you will see CINs that might have multiple legal entities. So I put on here, consider tax efficiencies, because some states, each time money moves from one pocket to the other, you're going to pay business and occupations tax. So thinking about tax efficiency as you decide on your legal entity and your structure is important, as well as if you're in a corporate practice of medicine state, that may influence your structure. There are a number of areas where state law is evolving and is different. So you may need a different license or registration for a clinically integrated network. You may be in a state that requires Attorney General Office reporting if you are forming an organization of multiple physician groups. You might be triggering insurance risk in terms of being treated as an insurer, depending on your structure. And there's a positive opportunity in state law where some state laws have quality privileges that allow clinically integrated networks or groups of providers to come together, work across those structures to improve the quality of care delivered to patients and still have some protection that encourages transparency and candor. So there are certainly some positives to take advantage of there. The other regulatory bucket we could talk and do an entire presentation on So I want to highlight the data and privacy. And as physician groups, you're well accustomed to working with both, but with regard to data use and security, really important as you're moving sensitive information around different groups within the CIN to be really thoughtful about doing that in a secure fashion. The fraud and abuse prevention laws, the nice thing is there are some new regulatory exceptions for Stark and anti-kickback that are geared specifically to value-based care. They are present a great opportunity, but they're very complex. So you'll want to think about those push-pulls in that with your legal counsel. Civil monetary penalties go to what types of incentives you can give patients to help align their actions with the goals of improving their care. So that's another one that there are some new exceptions that are positive in that regard. And then lastly, antitrust. Clinically integrated networks are a creation coming out of antitrust law that creates almost an exception to certain prohibitions. So working with good antitrust counsel to structure your legal entity and your exchanges appropriately, thinking about avoiding market concentration, whether you're exclusive or non-exclusive, and the implications of that. And then lastly, and most importantly, you must have either clinical or financial integration to be doing and taking advantage of certain strategic opportunities in the marketplace. So with that, I'm going to turn to Garrett, who's going to give us a brief example of what a clinically integrated network looks like. Thank you.
So we'd like to turn to a specific example of really what's necessary to apply the considerations that we've walked through previously and have discussed now in the context of really creating a CIN or an ACO. At first glance, this type of a model can honestly seem almost irredeemably complex. But as the name indicates, it's fundamentally a vehicle to accomplish clinical integration. And the vehicle for that integration is the CIN entity. And in many cases, the payer relationships that otherwise are already in existence with individual providers, with you or your group, are often maintained. And supplemental financial arrangements, value-based contracts are what are established through agreements between those individual payers and the CIN. So if you think about that CIN layer as adding or supplementing the fee-for-service existing relationships between the payers, that can start to kind of simplify what the purposes of the CIN really are. And it really, in order to permit the sort of joint contracting that the CIN is intended to be able to accomplish, the CIN has to have real integration. It can't just be on paper. So for instance, the CIN must be able to accomplish care coordination, management goals, and they have to have real penalties for failure to satisfy those participation criteria. The CIN has to be able to provide data to payers, to collect, aggregate, and even analyze data from participants. And in our experience, I want to highlight just a couple of the most significant issues that occurred during the course of the formation, but also highlight that many of these issues are also relevant if you're just entertaining participation in a CIN as well. First and almost foremost, governance structuring questions around how exactly the CIN will be controlled really come to the forefront. And I think whether or not you're participating or involved in formation of a CIN, who gets to vote on issues around how integration will be established becomes some of the most important and core considerations during the formation stage. Beyond that, these questions around capitalization and funds flows, will the CIN subsidize operations through fees, through a portion of savings, through debt, through a participation fee that it pushes down to the participants, are all very important considerations, again, whether or not you're forming or participating within that entity. Finally, one of the core things that happen in individual markets is a question of whether or not participation is going to be exclusive. And if the CIN that you're potentially involved in or entertaining joining is going to be the only potential vehicle that you can use for value-based contracting. And in many markets, there's competing entities that are involved in this space, so this becomes a very important consideration. And at the end of the day, if you are entertaining simply participating, the agreement that is proposed to you for participation in the CIN becomes the core area of importance for you as a physician or group. And you really want to concentrate in that document whether or not you're being asked to accept any downside risk, exactly what care protocols or policies you may be agreeing to adopt through membership in the entity, and to come full circle, that core consideration of whether or not you get a vote or get to sit on any boards that make decisions regarding operations of that CIN. Next slide, please. But then if you don't want to go the route of forming an ACO due to resource constraints or other priorities that you or your organization may have, we really want to emphasize that there are many other value-based contracting options out there, both as represented in this slide and in the graphic that Jeanna discussed earlier. And they involve varying levels of financial risk and requirements to integrate with other providers. All of these value-based models can honestly be accomplished without formation of an additional entity. And as you move right on this diagram, the financial and performance-based risk, of course, does increase, but this also comes with the potential for increased financial rewards, tied both to an ability to control costs and increase the quality of care that you and your affiliated providers are able to provide to certain beneficiaries. At the far left, as we've discussed before, you have this idea of a pure pay-for-performance contract with really no downside risk. You're likely very familiar with these types of models. Payers have an incentive to provide high quality care for their beneficiaries. So many network contracts already come with some portion of available reimbursement tied to satisfaction of either quality or cost metrics. In the center, we very intentionally differentiate between shared savings and shared risk models. These are both ACO-based arrangements at the end of the day, most frequently, but they are differentiated on the basis of whether or not the ACO is going to require you to repay any amount for failure to accomplish cost or quality goals. And then at the far right, in either direct to employer or full capitation arrangements, ultimately you're being asked to take on responsibility for the cost of a defined population. An important element of these models and prospective bundle models as well is that the funds flow can be manipulated to provide more constant, predictable revenues that are now disconnected from pure volume considerations. And especially as we look through the lens of what's happened over the course of the last couple of years, this can be a very important element of entertaining some of these value-based models to ensure that you're getting, whether it's a per member per month or some sort of care coordination fee, that's divorced in some ways from the actual care that you're providing to individual patients on an ongoing basis. Next slide, please. So now let's revisit quickly one of our initial slides in which we were outlining various contracting and value-based reimbursement models based on your tolerance of risk, resources available, and the degree of alignment possible with other ancillary related providers in your region. I'm imagining that based on your analysis of your internal strategic and financial considerations that Lori was outlining before, you may think that you're ready for some type of value-based arrangement. You likely have a high-level understanding of some of the differences between these models, but you may still be trying to figure out what makes the most sense for you or your organization. As a threshold issue, I really want to first emphasize that, again, that the success in this space depends so significantly on the ability to efficiently identify outliers, whether it's in categories of cost or quality, and to be able to implement solutions to really timely intervene in those types of issues. And honestly, also to be able to identify quickly and efficiently low-hanging fruit in relation to the factors and considerations that drive up costs in order to make accomplishment of the financial targets that are kind of a common element across all of these models a feasible goal. If you're perhaps only able to do monthly or yearly reviews of claims or real-time clinical data, that type of analysis may not be feasible, and it may make more sense to invest in those IT analytics resources first before pursuing some of the higher and resource intensive value-based models. Alternatively, it's often a feasible initial stage sort of phase one approach to concentrate on low risk models initially, to test the waters, develop those tools that are necessary, foundations for success in some of the higher resource intensive models as well. And alternatively, one of the other options that all providers have is that there are numerous entities now that play an intermediary analytics role, or through which you can participate in bundle payments or ACO-based models. And this route really depends on you committing through a participation agreement or other engagement to comply with data, care coordination, protocols, policies of that intermediary. And in exchange for that, you get access to their analytics resources while giving up some of the upside financial benefit, but getting a really significant opportunity to test out participation in some of these models. Next slide, please. Regardless of where you are in this process and your value-based journey, there are really some common questions that are valuable for you to consider that come up time and time again as we support our clients. First and foremost, as we've emphasized, you must consider whether you want to form a new risk-bearing contracting entity. This really opens the door to a potential world of commercial and federal-based value-based programs. If that's the route that you do want to pursue, it's important to recognize the fact that federal programs like the Medicare Shared Savings Program, direct contracting, they're all very highly regulated. And I sometimes joke that they come with a sort of very cookie cutter cookbook, and the application periods are limited. They have very tightly drawn performance years, and very frequently you're only given maybe one or two opportunities to enroll in these programs, whether annually or sometimes only every couple of years. And significant work really needs to occur prior to the application submission period. And a lot of preparation needs to come into play before you get to that stage of creation and application. And I just want to make sure that we emphasize that very frequently, if you are going to go that route, it can extend from 12 to 18 months before you're ultimately entering into an actual active performance period in those programs. Still, as we noted previously, if you're not going to entertain creation of a new entity, you're not barred from participation in these programs, but your level of control over ACO or other intermediary entity decision-making may be limited if you're only going to be a participant. But that participation comes with a really significant advantage of having access to both your network of participants within the program, but especially the data and analytics that come with participation in MSSP or other value-based enterprises. If the answer to the first question of whether or not you want to form a new entity is no, then there is still a world of possible value-based arrangements which can be accomplished through payer contracting, through arrangements with third-party conveners or other intermediary risk-bearing entities. The direction which you decide to go should really be dependent on your level of alignment with regional providers, your risk tolerance, especially in the context of your risk tolerance for downside risk and an obligation to have any sort of repayment obligation. The contracts for these arrangements don't really look like traditional payer agreements, but they frequently are built on the foundation of those existing arrangements. So you're not necessarily replacing your fee-for-service arrangements or fee-for-service rates that you have in place. Instead, you're supplementing them and agreeing to additional requirements in the cost and quality space. In each, you always really need to be careful about how the bases for measurement of performance are set, meaning that, for instance, in a capitation arrangement, what is the applicable population and what care is excluded versus included. Similarly, for bundle payment arrangements, you really need to concentrate on what exactly is included in the bundle. How's it defined? How long does it last? And what are the rules for excluding outliers so performance is not skewed by just one or two cases? Very frequently, payers will want to take full control over those determinations and only address them ambiguously, if at all, within the contract. The more detail that can be included regarding the rules around those calculations and measurement, the better off you as a provider participant are going to be, and the better you're going to be able to audit and understand the results of your performance in the future. And also, I just want to emphasize, kind of in closing, to always be wary of any entity that wants to take ownership of or really monetize your data in exchange for participation in some model. There are very frequently kind of limited financial benefits in those scenarios, and the core purpose of some of those entities is to increase their data sets. So I want to open the floor very quickly to my colleagues to weigh in on any other final thoughts related to their learnings from prior client projects, and then hand the floor to Lori to provide some closing thoughts as well. Thank you, everybody, for your time.
So there are a lot of opportunities in this space, and I would suggest that moving along the value-based care continuum in terms of what you are offering and able to do is really imperative. The world is changing. It's not a fad. Things are moving along. So pick those value-based strategies that really further your group strategy in the marketplace, and fit in, participate in opportunities that fit your level of readiness and your organizational culture, and the opportunities to drive the meaningful change in the triple or quadruple aim, and really drive innovation for the benefit of your patient. Many patients are looking for a different model for the delivery of their healthcare that keeps them healthier and able to navigate more easily a really complex system. So there are lots of opportunities to try different things out for the benefit of your patients. But as we've talked about, there are also some key risks to manage. One is being operationally ready, or having a plan to be operationally ready as you move along that continuum of risk. Really be thinking about how do the different payer activities and models influence population behavior change, so that you're bringing the patients along with a new model of care. Make sure there's reasonable levels of risk in the different payment methodologies, and really think about how you align, how you compensate either the groups or the physicians to drive the behavior that you're seeking in terms of access, quality, evidence-based protocols, et cetera. And of course, as you all know, as physicians, there's a regulatory environment in healthcare that you just have to navigate, and firms such as ours are happy to help you do that. And we are, as a group who practice in this area, excited about the opportunities that value-based care presents to really make a difference in the management of patients and their health. So with that, my colleagues and I thank you very much for the opportunity to be with you today, and thank you again.